Welcome back to The Explainer. Today, we're diving straight into part 3 of our comprehensive coding series. We're looking at something super specific, but absolutely crucial: the highly authoritative ICD-10-CM guidelines that govern alcohol exposure during pregnancy. You see, this is a really critical area of medical coding because it merges obstetric care, behavioral health, and pediatric outcomes into one giant, complex clinical web. And let me tell you, getting these codes wrong, it doesn't just muddy the clinical data. It literally triggers compliance audits and those revenue-draining claim rejections we all want to avoid. So let's break down the exact guidelines you need to know to stay in the clear. Okay, here's our roadmap for today. We'll start with an intro to obstetric alcohol coding, jump right into fetal alcohol syndrome and code Q86.0, and then look at maternal alcohol use under category O99.31. After that, we'll cover the mandatory dual coding rules, walk through a quick clinical scenario together, and finally, summarize our next steps. Right, let's get things off with Section 1, an intro to obstetric alcohol coding. The absolute foundational rule you've got to internalize right off the bat is this. In an obstetric scenario involving substance use, you are essentially treating and coding for two entirely distinct patients at the exact same time. It's a dual track. Managing these risks means completely separate coding rules for the maternal medical record versus the newborn's pediatric record. The mother's chart captures the complication of the pregnancy itself, while the newborn's chart, well, that captures the physiological manifestation of that exposure. Mixing these two up is literally a primary reason for major compliance failures.
So let's move on to Section 2, fetal alcohol syndrome and code Q86.0.
Let's look at how this actually impacts the newborn. The specific code we use here is Q86.0, which designates fetal alcohol syndrome. Basically, this is a congenital condition that affects newborns exclusively because of intrauterine maternal alcohol exposure. Now, the absolute non-negotiable rule here is that Q86.0 only goes on the pediatric or newborn record, and that is only when fetal alcohol syndrome has been formally and explicitly diagnosed by the provider. You never, ever put a Q code for a congenital condition on the mother's chart. The really crucial takeaway here is that this single Q code holistically captures a whole spectrum of very severe developmental issues in the infant. When a provider diagnoses fetal alcohol syndrome, they're identifying core clinical features like growth deficiencies, characteristic facial dysmorphology or abnormalities, central nervous system dysfunction, and other structural congenital anomalies. Q86.0 essentially wraps all of those complex physiological impacts into one comprehensive indicator right there on the newborn's chart.
All right, let's shift gears. Section 3, maternal alcohol use, category O99.31.
Having firmly locked down the newborn's code, we need to completely shift our focus back to the mother's record. Category O99.31 is your foundational base code here. This category is specifically built to capture any maternal alcohol use that complicates the obstetric episode, whether that happens during the pregnancy itself, right in the middle of childbirth, or in the puerperium, the postpartum period. If the mother is pregnant and using alcohol, this is exactly where your coding journey begins. Now here's the kicker. You simply cannot bill an O99331 code as a 4-character code. It's totally invalid. You absolutely must specify the exact timeline of the complication using a mandatory 5th character. So a 1 means the first trimester, a 2 is the second trimester, and a 3 is the third. If the complication pops up during the actual delivery, you use a 4 for complicating childbirth, and if it's after delivery, you use a 5 for complicating the puerperium. Precision here isn't just nice to have, it is an absolute mandate.
Moving right along to Section 4, mandatory dual coding rules.
So now that we have our base O code, we really need to talk about the biggest compliance trap in obstetric behavioral health. Coding category O99.31 all by itself is strictly non-compliant. Honestly, if you submit a claim with just that O code, it's going to trigger an immediate rejection. Boom, bounce back. To be compliant, O99.31 must always be sequenced first, but then it must immediately be followed by an additional secondary code from the F10 category. Think of it this way. The O code tells the payer, hey, this is a pregnancy complicated by alcohol, but the F10 code steps in to identify the precise clinical nature and severity, whether we're talking about use, abuse, or dependence. Let's trace how this exact sequence plays out. We start with the mother, applying that O99.31 code with the correct 5th character. Next, we follow the strict instruction to use additional code from F10, so we're stacking F10.1 for abuse, F10.2 for dependence, or maybe F10.8 for induced disorders.
That whole sequence completes the mother's record. Then, totally separately, if the newborn is showing growth deficiency or facial abnormalities, that generates the Q86.0 fetal alcohol syndrome code on the infant's chart.
Okay, on to section 5. Let's do a clinical scenario walkthrough. Let's actually pull all these rules together and apply them to a real-world chart. Imagine you're auditing right now. The documentation details a 26-year-old female patient at 20 weeks gestation, so she's right in her second trimester. The provider has formally documented a diagnosis of moderate alcohol dependence. How do we translate this exact clinical picture into a perfectly compliant ICD-10 sequence?
Well, here's your exact compliance sequence. Step 1, you absolutely must sequence the obstetric complication first, so we assign O99.312. And remember, that 2 at the end specifically denotes the second trimester. Step 2, we fulfill that mandatory dual coding rule by stacking F10.2 right after it. This specifies the exact behavioral health condition, which in this case is uncomplicated alcohol dependence. Finally, step 3, to ensure we have ultimate clinical specificity, we conclude with the appropriate Z3A code to formally document the exact 20 weeks of gestational age. This right here, this is a bulletproof, perfectly compliant coding sequence.
Finally, section 6, summary and next steps. Let's wrap up this explainer. By now, those strict boundaries between maternal and fetal records should be crystal clear. Seriously, if you take away only one thing from today, make sure you enforce this hard boundary. Dual O codes and F codes belong strictly on the mother's claim, no exceptions. Conversely, Q codes, specifically Q86.0, are reserved entirely for the infant's diagnosis. Never, ever cross the streams. As you sit down to audit your next obstetric chart, you really need to ask yourself, are you crossing those streams and risking a devastating compliance audit? Or are you accurately protecting both the maternal and infant records? Well, prepare for part 4, because we're going to pivot to the more technical side of things and explore blood alcohol concentration, or BAC, and laboratory toxicology CPT codes. It's a highly technical area, and you definitely won't want to miss it. Until then, like, share, subscribe to Decode Healthcare with Harshal.